talk about pain and opioid use among patients with kidney disease and sort of what's the latest evidence, what's the epidemiology, what things do we need to watch out for given the opioid epidemic that is entrenched in the pandemic that we're in. I am not receiving any money from any of the medications I'm going to be talking about from the pharmaceutical manufacturers. I do really like spicy food. I suffered minimally during the sriracha shortage, but it was okay. Okay, so I'm going to first discuss chronic pain epidemiology in this population and the commonly used medications for people with chronic kidney disease and chronic pain, and discuss maybe what's the average morphine milliequivalents we're talking about for patients with chronic kidney disease. And then when you're uncomfortable with a patient and the medications that they're prescribed, what signs do you need to look for in order to make a clinical decision maybe away from controlled substances if needed, if patients are starting to show signs of addiction? And how do we monitor that? How do you assess that, and what's the evidence base for doing that and just feeling comfortable in how you're prescribing? And then specifically what Penn State does to address addiction, but this kind of model is pervasive at this point, thankfully, and so every health system has something similar to what we're doing. So chronic pain, as you know, is extremely common in people with chronic kidney disease and end-stage renal disease. And when it's left untreated, it's catastrophic. It can cause poor quality of life, problems with adherence to dialysis. People don't show up for their treatments. It can kill people. It can cause depression and anxiety and fatigue. And so it's a problem deserving of treatment. But in this population, there's a disproportionately higher use of opioids. And a lot of that has to do with the fact that, there's the lack of availability and sort of evidence for non-pharmacologic options, which we'll talk about in this population. There's a paucity of safe non-opioid options to use as medications. Greater than half of all end-stage renal patients, though, receive an opioid prescription, which is over 3 times the rate of the general population. So important to keep that in mind. 20% of people with end-stage renal disease are on chronic opioids, and with chronic opioids carries risk: falls, mortality, altered mental status, hospitalization, all kinds of things. So non-pharmacologic approaches, we are aware of things like cognitive behavioral therapy and physical therapy and maybe acupuncture and some other mindfulness kinds of techniques. But these have limited evidence in individuals with chronic kidney disease. However, what evidence exists is positive, and I'm certain that there's evidence that it doesn't harm. So it is beneficial to try these approaches with individuals who have pain that are unlikely to improve with surgical or other treatments. So with pharmacologic approaches, there's medications that you can use for neuropathic pain, such as the gabapentinoids. However, these need dose adjustments for chronic kidney disease, and you need to administer them post-hemodialysis. Do not co-prescribe with opioids because the two together can have harmful sedating effects with an increased risk of falls and hospitalizations noted. There's also the tricyclic antidepressants and the serotonin noradrenergic medications, reuptake inhibitors. And many of these can be anticholinergic, which means they can cause altered mental status again. So it's something to be mindful of with patients, and certainly start at the lowest dose and go slowly. And it can cause inappropriate ADH. So, so important to monitor folks that are on these medications. And then we get to opioids, which you may use after all options have been tried. You want to use them sparingly at the minimally effective doses. You want to establish therapeutic goals. I want to be able to dress myself and not be in pain. I want to be able to go to the grocery store and shop for food and not come home and feel like I need to sleep for the rest of the day. Sort of really tangible things that people need to be able to do. And so then maybe you can pre-medicate prior to those events and then not medicate, at other times. And certainly before starting to write for these medicines, using the opioid risk tool, which is a tool that can really maybe screen people who might be at higher risk for prescription misuse, where if there's a family history of substance abuse or a personal history of substance abuse, and they also screen for mental illness as well. And I would think that they part of that is also just determining a person's ability to manage their own medications and their own IADL, so that they're really able to do what they're able to function well. They have good executive function and can manage their own medications. So now you've decided to prescribe opioids for your patient. And what can you do to make that patient as safe as possible and not accidentally hasten someone's demise? There are ways to do it safely, and you want to monitor. And so how do you monitor it? Well, it's really important that you don't profile your patients, that you make a decision to do the same procedure for everybody that's getting opioid prescriptions. And so you want to do urine drug screens for everyone, or mouth swabs if they're anuric, to just make sure that people are taking their medicine as prescribed and they're not taking anything else that might interfere or make their medicines a little more dangerous than you had anticipated. It's really important to destigmatize these tests too. If patients push back on that, describe the gazillion other ways they're currently being monitored and say that, this is yet another way to ensure your safety. And there are medicines that are safer to use that are not renally metabolized that can be used in this population, such as oxycodone and fentanyl and methadone and buprenorphine and hydromorphone. So going through some of these medicines, I am an addiction medicine doc and I'm medical director of an opioid treatment program at the Pennsylvania Psychiatric Institute. And so I frequently treat people with opioid use disorder, and I use methadone and buprenorphine medications to treat people. And methadone can be used in the treatment of opioid use disorder, but it is also a very effective pain medicine that can be prescribed without any special licensing if you are prescribing it 3 times a day for pain. So it is an important tool to keep in mind because it is a very inexpensive medicine that can be used to manage chronic pain extremely effectively. It has a 6 to 8 hour analgesic half-life. There's no dose adjustment needed for chronic kidney disease as it is metabolized in the liver. It's not renally dialyzed, so that's important, but it can prolong your QT, so it's important to measure EKGs. If the EKG is not readable because a patient may have underlying heart structure problems, then you might want to reconsider the use of methadone in those patients. But you definitely want to monitor EKGs, especially with the addition or subtraction of new medications in this population. And you can prescribe it 3 times a day. And when you do not need federal licensing for it. What you can't do is diagnose somebody with opioid use disorder, prescribe methadone as a treatment for opioid use disorder out of your practice. That's the only restriction for methadone. But if you write it 3 times a day as needed for pain, it is something that everyone here with a DEA number is capable of doing. So buprenorphine is another long-acting opioid, which works slightly differently. It is a partial agonist, so that means that it partly acts on the opioid receptor as an opioid, but it also acts as a blocker at the same time. So it does not interact well with other opioids, and if you have other opioids on board first before giving somebody buprenorphine, it will put them into withdrawal. What that means, though, is that it is an incredibly safe medicine, and the risk of overdose on buprenorphine is magnitudes safer than any other opioid, in case you're worried about it. There's no dose adjustment needed. It is not dialyzed. And it can be prescribed for pain. So there's a formulation that's used to treat opioid use disorder where it's co-formulated with naloxone. And the reason for the co-formulation is to prevent injection, which can then cause precipitated withdrawal. But for pain, there are formulations of buprenorphine alone that are usable and usable for people without any sort of special certification. So there's the buprenorphine patch you may be familiar with, and there is a buprenorphine strip that you can put inside the cheek that dissolves, which also helps with pain. So why do we constantly rub our hands together with worry and talk about this in such, breathy tones when we talk about it? And it has to do with death. We worry about hastening it, and we don't like to kill people. That's why we do what we do. And the opioid crisis has really reached a fever pitch, especially during the pandemic. Overdose deaths have increased 30%. So we're looking at over 100,000 deaths per year from drug overdoses, which actually at this point has far surpassed any of the highest years of deaths from the HIV epidemic. So if this were another infectious disease, we would all be absolutely terrified of that. And so, okay, so you've decided to write for opioids for your patient. Maybe they're calling you a couple of days early, wondering if they can get an increased dose, or they ran out early, or they don't know what happened to their medicine, or they lost their script, or something's happening and it's, it's activating your spidey senses and you're wondering, what do I do now? So there are definitive signs of aberrant drug-related behaviors that you want to keep in mind. People will frequently report lost or stolen prescriptions. This is less frequent if you're doing electronic prescribing, but in the event that you're still using paper prescriptions, you really have to be clear with all patients from the outset about the expectation that you expect them never to lose their prescriptions, and if they do, you can't refill them. If they're requesting early refills, that could be a sign that either they're taking more than prescribed or that they might be selling the medicine that they have. So another reason to be doing drug screens on everybody, however you do them, so that you can assess whether they're actually taking the medicine. If they're frequent emergency department visits, if they're doctor shopping, you can see all that information on the prescription drug monitoring program. So really important that you check that with each patient, with each visit every time to review that. If their drug screen is negative for the prescribed substance, you want to make sure that they're not trying to, that they're not selling the medicine, if they're taking too much, or they look visibly sick in front of you because maybe they're experiencing some withdrawal. And then if it's also positive for a non-prescribed substance. So what do we typically do in the offices and how well do they work? So we use contracts all the time. What are those about? We do drug screens, either mouth swabs or urine. We check the prescription drug monitoring program. And then there's something called random callbacks or pill counts, which is a technique that I think is very frequently underused and could be used to a lot of good therapeutic results. So going into contracts, there's very little evidence that they work. And these are the quote unquote pain contracts where it enumerates the 20-odd reasons why you're allowed to discharge them from the practice if they're a hair off on how they behave. And these contracts are really just sort of CYA medicine, for lack of a better term, and really just are an excuse to stop caring for a patient that still needs care, even if you're uncomfortable doing it. Making sure that they have a handoff to a provider if you're less comfortable is very important. Many states require these contracts, but opioid misuse has only been found to be modestly reduced with contracts, and it can be harmful. It can destroy a patient's trust. It can destroy therapeutic relationships. It certainly didn't fix the opioid epidemic, and I think that setting out certain expectations, like you expect that their prescriptions won't get lost. You don't expect them to run out or lose any of their medicines. You don't expect them to get medicines from different prescribers. You can set your own rules, but having patients sign something that puts them like in this kind of clause with you is not. It's not therapeutic, and I don't think it's necessary. And at any point, you can change clinical course based on your clinical opinion. So many patients don't even know that they've signed a contract, and there's low health literacy to understand terms of the contract. So it's really not meaningful for anybody other than your office manager or risk management. So what about a drug screen? And so I put up urine drug screen, but obviously to my audience, it can be a mouth swab as well. And these screens are critical to determine adherence and other illicit use. They need to be random, and they're not used routinely in primary care or chronic pain offices or any other specialty offices. It boggles my mind that it's not used routinely. This is the stuff that we need to be doing everywhere. And it's just a part of what they, what should occur as we monitor these patients. It's so important to destigmatize it. We're doing this. I expect you to leave a urine or a mouth swab with every visit, that we give you a prescription, or at least 4 times a year, or whatever set interval you've decided with your practice based on your patient population. But if there's any pushback, you can just say how much monitoring they currently get with everything else that they are doing, right? Certainly people with chronic kidney disease, this is not going to be the only medicine that they're on, and they're going to get all this other monitoring. So any pushback from that, oh, you're making me feel like X, Y, or Z. No, there's an opioid crisis, don't you know? And we want to make sure that you don't die from that. And you're here so that you don't die from other things. So why don't we just throw this on the pile? So that kinds of stuff. The other thing is you want to make sure that you test for the opioids that you're prescribing. So you need to make sure that your test is valid. There are many urine drug screens or mouth swab screens that you'll send to that will only test for opiates with a T, and that only can detect morphine and morphine metabolites. It does not detect the synthetic or semi-synthetic opioids with a D. So methadone, buprenorphine, oxycodone, and fentanyl are 4 entirely separate tests that are separate from each other. So if you're prescribing a fentanyl patch and somebody is testing positive for opiates with a T, they're taking something else. So it's important to remember that. If you're using a point of care urine cup, like the ones that are pictured, there are lots of things that can cause false positives for benzodiazepines, for amphetamines. Really, with amphetamines, if you breathe hard in the wrong direction, you can test positive for amphetamines, but you want to send that out for mass spectroscopy confirmation, and you'll see that it's negative. For benzodiazepines, sometimes gabapentinoids can cause false positives, and sometimes sertraline can cause false positives in benzodiazepines, and again, a confirmation test would show that that's true. However, I will say that cocaine and opiates, if those show up positive, it's because they have exposed themselves to cocaine and opiates. So important to have that discussion. And how do I have that discussion with patients? So sometimes it can be a tricky conversation to navigate, and I try to disembody the patient from their test result so that it's not an accusatory, what have you done today kind of question, and they don't need to confess all of their sins. I just say, this has appeared in your test. Can you tell me a little bit about that? And then they'll talk about it, or they won't talk about it, or they'll say, oh, I have no idea how that got in there. And you can say, like, you can either get into an argument of whether a patient is lying to you or not and risk severing the therapeutic relationship, or you can just say, okay, but let's try to find a way for this to not be in your next test, if that would be okay with you, right? And it sort of gives them an out, lets them save face. Eventually they'll open up, and you can just reiterate that you're not there to police anybody, you're there to care for them, and if they need more care, you want to know about it so that you can help them get it, because addiction is a treatable illness. The other thing to keep in mind is that we have been prescribing opioids, which is why we're in this epidemic, but where the opioids are most prescribed are actually where the most overdose deaths are happening. So really important for you to be aware of your prescription as currency for the area in which the patient may live. So everybody has the basic idea of general things like gun safety, right? Where you have to keep the ammo separate from the guns and lock everything up and keep them safe. But not many people know that they need to lock up their medicines. And people will give medicine away, it'll get stolen, it sort of makes its way into the neighborhood. And so it may not be the patient itself that's suffering, but it could be everyone around that patient. Another reason to do drug screens. And you want to have a policy for everyone so that nobody feels particularly targeted. This is what we do for everyone. This is office policy. And that's all you say, and if people decline, you can just say, well, this is part of our policy. You're free to seek treatment elsewhere, but we can't continue to write for these meds. It's for your own safety. And so you can do compliance monitoring. For the first 3 months, you can do it monthly. If everything seems fine, there's no aberrant drug-related behaviors, you can reduce seeing the patient in clinic to quarterly or semi-annually. And so the prescription drug monitoring program is awesome. In Pennsylvania, we were state number 49 out of 50 to go live, which was super fun. I arrived at Penn State about 6 years ago, and that's when the PDMP first went live. And I was like, oh boy, I had no idea that I wasn't going to be able to practice the medicine I practice without this. Glad it finally came up. But Missouri was the 50th state for anyone paying attention. And there's a lot of good evidence for using the PDMP in that it has stopped prescribers from writing as many opioids. However, that also didn't mean that the epidemic went away. So it has helped, I think, our side of the street to be a little more cleaned up, but it certainly didn't solve the problems. And the last monitoring thing is a random callback that, you want to make sure that pill counts are random and for everyone. So what is a callback? If you're giving somebody a month of medicine, maybe day 22, you call them and say, hey, we'd like for you to come into the office and bring your pill bottles, and we just want to count the medicine that you have left to make sure that you're taking your medicines appropriately, and want to make sure that you still have it. And so they have 24 hours to come in and present their medicines. It means that they tell the clinic when they're going away on vacation so that they don't get a callback when they may be away. But again, having a policy and a procedure for your office clinic so that patients are aware that this is what you're doing and you're doing it for their own safety. And they may say to you, boy, this is so fussy. I don't want to do anything this fussy. And then you say, well, we don't have to write for opioids. Like, we could try other things. And so it's really, these should go hand in hand with each other. And so, all right, so you do all these things, and suddenly you have patients that have a diagnosis of addiction. And what do you do with these patients once you're like, wow, I'm really worried about you, and I'm concerned that you may have an accidental overdose. Sometimes I don't even use the word overdose, and I'll just say sometimes I worry, that you might poison yourself. I use a lot of self-deprecation. That's kind of my persona. So I'll just say, I am a professional worrier. I am paid to worry, but I also have a natural talent for it. And I am worried that you are going to poison yourself with this. And then they'll laugh and be like, ha ha ha, don't worry about me. And I'll be like, actually, and then I just go for the jugular and I say, this is, so they're disarmed, feeling comfortable. And then I just say, hey, we're not going to write for this medicine today because I want to make sure that you don't die. And that's because I really care about you. And I would say, with that, you're still going to get 10% of patients that will, get fired up and say, you're not a real provider, I'm going to go to X, Y, or Z and get another prescription. And then you can say, I'm so sorry, But of that 10%, 60 will come back within the next 2 days and apologize. And so make sure that you are connected to your addiction medicine colleagues, that you can refer them, or you can actually do it yourself, and it's not hard to do. So you do need an X waiver to prescribe buprenorphine, but you don't need to undergo the 8 or 24-hour training, depending on your degree, to write for less than 30 patients. And so what you would need to do is go on the SAMHSA.gov website and apply for your X waiver in order to be able to treat less than 30 patients in your panel with buprenorphine. If you decide, hey, this is really cool medicine, I'm making a lot of people better, which I totally relate to, you can do the training, and then you can treat up to the limit of the waiver that you have trained for. So I believe the first year is 30, but it might actually be 100 at this point. So I'd have to check. At Penn State, we use a hub and spoke approach to opioid use disorder. So we have a specialty clinic, which is our methadone treatment clinic. And we also do buprenorphine and naloxone in psychiatry, and some scattered primary care, but we need to tighten that up a little bit more. But it is a specialty clinic site. So just like nephrology is specialty, addiction medicine is also specialty service. It is no longer siloed at Penn State. It is well integrated as a referral service, and we get tons of referrals from people. And I'm delighted to say that even inpatient, formerly known as detox facilities, are now starting treatment and getting folks set up with treatment after their discharge, which is amazing. And we also work with prisons that have continued medicine while they are in-house, so that they can have good transition of care afterwards. So lots of great options for patients that you're making a diagnosis of addiction on. And that's all I have.